So hi everyone, and thank you so much for joining us today for what promises to be a really interesting, insightful and inspiring event. My name is Nicola Chicken and I'm a project manager leading on the Medicine Safety Programme in the Yorkshire and Humber Patient Safety Collaborative. So I'm very excited to be hosting this webinar today and to welcome our fantastic guest speakers, as you'll see as they speak, are all really passionate about this subject. So I'll start with a little bit about what the Patient Safety Collaborative is for anyone who's not familiar, or a bit of a refresher for anyone who is. So there are 15 patient safety collaboratives in England, each hosted by an academic health science network, or AHSN for short, and that's in the 15 regions across England. The aims of the Patient Safety Collaborative include creating safer systems of care and a culture of safety, learning from errors and excellence, reducing harm and sharing learning. And this webinar today is hosted by the Yorkshire and Humber Patient Safety Collaborative, which is delivered in partnership between Yorkshire and Humber AHSN and the Improvement Academy, who are part of the Bradford Institute for Health Research. So the Medicines Safety Improvement Programme, or MedSIP for short, as I'll refer to it, is one of 5 priority areas within the National Patient Safety Programme. And the MedSIP programme aims to address some of the most important causes of severe harm associated with medicines. And one of the current priorities within this programme is reducing harm from prescribed opioid medicines used in chronic non-cancer pain. So the aim of this webinar today is to bring people together in the spirit of shared learning, sharing of good practice, and either hopefully expanding your existing knowledge and interest through some real life examples from the West Yorkshire region, or sparking an initial interest in this subject and finding out how you can make a difference. So I'll just do a couple of bits of the usual housekeeping. So we have got a really big audience today, which is fantastic. So thank you everyone for joining, but please do stay on mute, just so that our speakers can speak without distractions. Please add any questions, comments and thoughts that you might have into the chat, and we will pick up as many of these as possible to be answered in the Q&A session at the end. This session is being recorded and the recording will be shared with all registered delegates, and slides will also be shared with all registered delegates. So I'll quickly cover the agenda with our brilliant guest speakers. So first of all, we have Liz Farquhar, Advanced Clinical Pharmacist, and Vivian Laidler, Clinical Psychologist, speaking on their multidisciplinary approach and the importance of building patient relationships. We then have Kerry Page, Programme Manager for Rethinking Pain Service, speaking on her experience of the socio-economic and community support elements of chronic pain management. And she'd also like to welcome Richard Taylor to share his experiences of living with chronic pain. And then we have Lindsay Clayton, Medicine Safety Officer at Wakefield District Health and Care Partnership, speaking about the use of prescribing data to identify patients potentially at risk of harm from opioid prescribing. We'll then pick up any Q&As, any questions from the chat for a Q&A session. So I'll share those with our speakers to answer. I'd then like to do just a bit of a word cloud, which is a function on Teams, just to get people's thoughts on any future topics that they might want to see around this subject for future webinars, and then we'll bring it to a close. So we're hoping to end at least by 2:30. And now I will hand over to Liz and Vivian, who run a chronic pain management clinic together at Leeds Teaching Hospitals NHS Trust. And as mentioned, they'll be speaking on their multidisciplinary approach and the importance of building patient relationships. So over to you, Liz and Vivian. Thank you.
Hello, hi. Can everybody hear me okay? Give me nod.
Yes,
great.
thank you.
Thank you. I'm Vivian. I'm a psychologist in the pain service at Leeds Teaching Hospitals, and my colleague Liz is also here. She's a pharmacist. We're going to present together. So we've been working alongside one another, running a joint clinic, looking at medication review, medication reduction. Been running our clinic together for about 9 years, I think now. And for both of us, working together has really shaped our individual practice. And what we wanted to do today is share our experiences and share a bit about what we've learned. We're absolutely not experts, so we're not putting ourselves forward as experts, but we just hope that our experiences might help you in practice. So I thought I'd just briefly say a little bit about why do we have psychology in the pain clinic. So we know that pain doesn't just affect you physically. So pain affects your emotions, your thoughts, your relationships, what you can and can't do, your activities, your interests, all kinds of things. It's really, really difficult to live with. So it's important to say from a psychology point of view, we don't think your pain's all in your head, we don't think you're making it up, we don't think you're mad, and that's very much the message that we would give to the people that we work with. Pain's just really hard to live with. So I will pass over to Liz.
Thank you. Next slide, please, Nicola. Thanks. So as we all now are aware, the use of strong opioids in the management of long-term pain is no longer recommended. There's little evidence to support sort of extended sustained benefits, and there's increasing amounts of evidence that shows that they can cause harm. And we've now got in place a number of national initiatives to try and drive forward change on this. I'm sure you're all familiar with these, the MedSIP programme, which Nicola has referred to, QAF, the DES, there's lots of things in place. But I guess a lot of you will know from your own experience, even though all of this stuff is around, it still really can be very difficult to get somebody to agree to take less opioid. I'm wondering, this is still a challenge. Why is that? So there's a few things to kind of bring in and to try and help unpick this a little bit. Next slide, please. So some of the things I think it's useful to consider is that remembering pain is really, really complex. It's affected by so many different factors. It's subjective and it is really, really difficult to measure. Pain affects every aspect of somebody's life, and that can be really challenging for us to fully understand as a healthcare professional. We don't have validated tests and measurement tools that will actually give us a really good idea of what pain is like for each individual person that we see. Taking medication might be somebody's only strategy for managing their pain. They might not have anything else in their kind of box of tricks to try and manage it. And for a lot of people, they already feel like they are struggling to cope with their pain on a day-to-day basis. So if we then come along and we start a conversation with them about stopping their only management tool, it's kind of understandable that we might meet a bit of resistance. Somebody might suddenly feel quite threatened, quite fearful or anxious about what actually that means and what it might involve. So I think it's really kind of helpful to acknowledge at this point, next slide please, Nicola, that really when we are approaching somebody and talking about reducing opioids, we are doing more potentially than asking someone to just take less medication. What we're talking about is perhaps asking somebody to change their whole management strategy and challenging their behaviour around their pain. So what we're really talking about, as well as taking less medicine, is actually behaviour change. And so if we can appreciate that, we can then kind of perhaps use that to shape our approach into how we might discuss this with someone. So how might you approach the topic of deprescribing with somebody? So the first, probably quite obvious thing to say is that it's going to recognise it's going to take more than just coming up with a really well-designed reduction schedule on the practicalities of how you reduce an opioid. That might come and that'll be necessary, but not until you've actually kind of got to the point where somebody's ready to do that. And then also this idea here of actually telling someone it's the right and obvious thing to do is unlikely to produce the desired outcome. It's really tempting as healthcare professionals. We know we're right, we know this is the obvious thing to do, but it's not necessarily going to bring about the right change. in somebody. Miller and Rolnick, who are the founders of motivational interviewing approach, which we'll come on to discuss a little bit more of in a moment, state that providing well-intentioned advice to somebody who's not yet ready to hear it might actually result in further resistance. So your well-intentioned advice might actually end up doing more harm than good. Something that's kind of summarised by the cartoon here. Next slide, please. So as healthcare professionals, we're generally kind of trained and encouraged when you're looking at how to approach something to see if there's any evidence-based guidelines, or you kind of review the best evidence for practice. And you know, as you probably know, for opioid deprescribing, there's not a lot of stuff out there. Some bodies have now kind of produced guidance and pulled stuff together, and the real consensus from all that's being produced is that really you need an individualized approach. There isn't a one size fits all, so actually we're probably not going to end up with some really nice step-by-step guidance of protocol driven, this is what you do next. And I guess that makes it a bit more challenging for us as clinicians, that it's very much over to you to use your clinical judgment and your skills to work with someone to kind of design the best way forward. I've come across a couple of papers recently where there's been some research done into why opioid deprescribing is so difficult. And although the kind of the summary of the papers is recognise there are kind of barriers for both patients and the practitioners involved, and although that hasn't given us a solution, I have kind of found it encouraging that enough people have found this a difficult subject to and topic to have improvement on, that other people have thought it's worth researching. So there might be some stuff in the future that comes out to help us again sort of shape moving forward with this. Next slide, please.
So we think this is a really important principle which underpins our clinic, the idea of connecting first and educating second. So some of you might have heard of Dr. Rangan Chatterjee. He's written a number of books. He does podcasts on the topic of lifestyle medicine and helping people to make healthy behaviour lifestyle changes. He did the Doctor in the House TV programme some years ago. Some of you might have seen it, where he went to live with people and tried to help them make lifestyle changes. And what he said, reflecting on his experience of doing those programmes, was that what he found most important was connecting first and educating second. So I just think that principle is so important. And it really fits with the ideas from motivational interviewing, that simply telling people what to do doesn't work. Annoyingly, really annoying, even if you're right. So you might have the best ideas about what someone should do, but if you just tell them, it probably won't work. And we really like this quote from Maya Angelou. So people will forget what you said, but people will never forget how you made them feel. And I think that's a really important part of our work. Have the next slide, please. So in psychology, a big part of how we work is building the therapeutic relationship. So we would say that you can't work on any other issues without first doing this. So we think that the relationship that you have with the person you're working with is actually the most important factor in bringing about change. So without your relationship, the person's unlikely to make changes anyway. So actually, it's really, really important to invest your time, spend your time building the relationship, because this is what will help to move the person forward. And can I have the next slide, please? So Liz mentioned motivational interviewing a few minutes ago. So this forms the basis for what we try to do in our clinic. We think it's really well worth looking into further. So if it's not something that you're aware of, or if you don't know loads about it, we definitely encourage you to do some reading, or ideally, if you can look for and book onto a course in motivational interviewing, that would be super helpful. So we're not able to give a really full explanation in a short time today, but I will try to give a very brief overview. So firstly, it's really important to resist the urge to tell somebody what to do. It's so tempting, especially as we've got really good ideas about maybe what a person should do, but we need to resist the urge to be telling them. Instead, it's actually the person's own reasons for change that are most important, not our reasons as the healthcare professional. So this means listening is really, really key to find out the person's reasons for change, their own ideas about solutions. And motivational interviewing would say it's most powerful if the person can talk about these things themselves. So if they can talk about their reasons for change and their ideas about how to move forward, rather than you doing the telling of them. And then also we try to empower the individual to feel that they can change the behaviour. So they're the one that's obviously got to do the change in real life, not us as healthcare professionals. So empowering them is really important. And this might be through working out small manageable steps with them, starting where they feel that they can start. And I would argue that listening is actually key to all of these principles that we've got on here. So instead of telling someone what to do, we're instead going to start by doing lots and lots of listening to get to know them and understand them. We're going to try and understand and help the person to find their own reasons for change. And again, we'll do this by listening. And we're trying to empower the person. And we can do this by allowing them to feel heard. That's really, really powerful, and listening as well to what they feel would be manageable. So how to put all of this into practice in our appointment. So it's important to spend time understanding the person. Again, listening, understanding what it's like living with pain for them, understanding what's important to them, and this will help you to build your relationship. This all takes time, so we think this is absolutely worth the investment of time, and that actually you're not going to achieve change without this. So, you could imagine a world where you could do something with the person more quickly, a quick 5-minute phone call or something like that, but it's not going to lead to the changes that you want. So actually investing your time at this point is really, really important. That might involve some sort of bigger changes. So maybe making time in how your clinics are structured. Also kind of giving the person you're working with the impression that you've got loads of time, even though you're probably really rushed because it's the NHS. So we also think working with somebody face to face is way better than a phone call, if that's at all possible to set up. I think phone calls are really, really difficult if you're trying to discuss tricky things or trying to build a relationship with somebody. So definitely recommend face to face contact. So if we can have the next one, I'll pass over to you, Liz.
I'll unmute first. Thank you. So the next step is kind of having hopefully established, got to know the person a little bit more. You can then move on to share what you know. So it's an opportunity to share the facts around long-term opioid use, the lack of efficacy, adverse effects, and hopefully you'll be able to tailor this more appropriately to the person because of the kind of time you spent getting to know them first. I think it's often helpful at this point to really just be able to pitch it, and it's an opportunity to explain why we're concerned as healthcare professionals. And it's really about wanting to know how well a medicine is working. Explain it's how well a medicine is working for you. There's kind of these reasons why it might not be, but we need to work out how that works out for you. And I often find myself talking about the aim of any pain intervention is to improve quality of life, because that's what the pain threatens. That's what it robs people of. So when we're thinking about how well does a medicine work for somebody, it's really important obviously to look at the benefits that it brings, how well it's working, but it's also really, really important that we look at any side effects that come along and what impact are they having on somebody's quality of life. And it's really about reviewing it as a balance. And I often end up doing this kind of idea, talking about if you had a set of weighing scales actually, and you're able to review the positives and the negatives of a medicine, how would it stack up for you? And this can often be really helpful. Often as you're discussing side effects, people can start to identify things and experiences that they might be having in their lives and realise perhaps some of the negative effects that opioids are having that they weren't aware of before. And this can perhaps start to come through and build some motivation for having change. Next slide, please. So having done those two things, hopefully you can then move on to discuss the future. And using shared decision-making approach here is just vital. What you're looking to do is take kind of what you know as the expert in medicines and what the person knows as the expert in themselves, and kind of bring that together and look about then how you can agree a way forward. I think it's really important at this point to be thinking about expectations on all sides. It's really good to be able to help the person set realistic expectations. What you're aiming to do is you're wanting to support this person in learning to live well with pain, and medicines, you know, can play a part in that, but we need to make sure that it's, you know, kind of the best that it can be for them. And so you probably need to be able to have honest conversations around their treatment options. I don't know, you may have had the experience sometimes when you've talked stuff through with people, they are able to say, yes, actually, I can see lots of good reasons why I need to stop opioids, so I'm happy to do that. What are you going to give me instead? And then that can be a really, you know, that's a really important conversation to have, and I would say especially important if the answer actually is nothing. And it's really important to be able to talk that through and explain to somebody and help them really understand kind of the options that are available, and kind of bringing into the whole idea of sort of informed choice and making sure people fully understand the situation. And I think, again, in here, you can sort of start to talk about the fact that just because there isn't something else available, it still doesn't make it the right thing to do to continue with opioids if they're not bringing about any benefit. At this point, it's also probably helpful just to check in with your own expectations as well. Obviously, we've kind of got this aim of trying to reduce people to taking 120 milligrams of morphine or less in a day. But it's probably helpful just to think about the person sitting in front of you and to think, is that actually a realistic aim? If you've got someone who's been established on like 300 milligrams of morphine a day for 15 years, it's probably going to be a long way down the line, if at all, that they're able to achieve that. So it's really about thinking what's a realistic aim for this particular person. And any reduction in opioid that we can bring about is going to be hopefully a positive step forward. I think there's also probably worth noting there's probably some expectations about the systems that we work within as well. Having the targets and incentives are great. It's really helping make it a priority and kind of giving us more resources to address this issue, which exists for a lot of people. But it might possibly result in a bit of a dilemma for us. We've got the kind of the aim and the guidance to reach this target of getting people below this dose of 120 milligrams. But then we've also got the kind of the responsibility to try and make sure we're helping a person make the right choice about what medicine's right for them. And sometimes those two things might feel a bit conflicting. So that can be a bit difficult. And it's probably also worth just mentioning quickly about how we measure outcomes. Often, traditionally, our outcome measures are going to be quantitative. So like for here, we may well look as our kind of outcome measure a reduction in the amount of opioid that somebody's taking. And that is our final endpoint. But for that endpoint to be achieved, there's quite a few things that have got to happen along the way. And that's going to be things around sort of people's attitudes and beliefs and their behaviours and things, which are quite difficult to measure and don't fall into the things that we normally look for. So it might be worth kind of, you know, being aware of that and thinking if there are other stuff that you can put in to just check and see what progress people are making. And something else that some primary care colleagues have mentioned to us is that in order to kind of try and improve their options of making relationships with people, is that they've had to kind of review their appointment times and their settings, so they're able to have times where they're able to allocate more than 10 minutes or 15 minutes for a patient appointment, particularly to begin with, so they've got an opportunity to kind of get to know the person and start them off on their journey. Next slide, please.
So what if the person that you're speaking with says no, that they're not happy to reduce their medication? So I think, you know, that absolutely happens. It's definitely hard to know what to do, I think. So I wanted to share that experience. I guess as a default position, it's really useful to go back to listening. So try to understand where they're coming from, try to explore barriers. And actually by doing that, you're obtaining really useful information. So anything that you can find out by listening at that point is a really good use of your time and really, really helpful. So thinking about what not to do, it's helpful not to try and argue with the person or to try and challenge them or try to convince them or persuade them. And I guess we all know this from our own personal experiences. If someone's trying to change what we're doing, we just dig our heels in further. So that tends to not be as helpful. I think it's important not to see this as our own sort of personal failure. If somebody's been in this behaviour pattern for years, it's probably unrealistic to think that they're going to change that in one conversation. And change is very much a process, and this process takes time. So don't panic and don't take it personally, or don't see it as a failure. Can I have the next slide, please? So this is the stages of change model, and we really like this idea that people are at different stages of readiness to change particular behaviours. We all are. So actually you might spot yourself on here in relation to different behaviours in your own life. So the pre-contemplation stage, we're not aware that we might need to make a change. We're not even registering this as something that's an issue. We're kind of not aware of it. At the contemplation stage, we're maybe starting to think about changing, maybe aware this might be beneficial, or maybe that we're feeling that we should make a change, or this is something we might need to change at some point, but we're not really ready, or not really thinking that we're able to do this just yet. At the preparation stage, we're actually getting ready to change. We're maybe planning to do it. We're working out what to do, working out how we're going to do it. We're in the process of starting to change. At the action stage, we've maybe just started to make the change. We're doing some things differently, trying it out. And then obviously for that change to persist, we need to maintain it. So we need to then keep going with that and get it really into our routine and into what we do kind of every day over the longer term. So we think this model is really useful to have in mind as a bit of a guide, as all patients that we work with will arrive at different points. So some people are ready to make a change straight away. They might just need a little bit of advice or some practical tips more often. Other people might be not really recognising that this is an issue, not feeling that they can do anything about it. And our job's actually quite different there, I guess. We're aiming then to maybe just move them along a little bit. So I like the idea that we can be sowing a seed of change that might not look like it's a change straight away, but maybe we've planted a seed and that person will go away and do some thinking about it and maybe think more about making changes and be ready to make changes later on. And I guess all this work is the long game, really. So we're in this for the longer journey. So that's really important to remember. Can we have the next slide, please?
So that's a bit of a whistle-stop tour of what we try and do. I think we've tried to cover a lot of stuff in quite a short time, so I hope all of that has made sense, and there might be some stuff in there that feels kind of appropriate and useful and things that you may be able to take forward. So just in summary, so opioid deprescribing can be really complex. There's lots involved in doing it, and it's often likely to involve more than medicine reduction. It's about behaviour change as well. And so for that reason, it's often that sort of different approaches are needed, and things like motivational interviewing techniques might be helpful. It's good to check in about your expectations of the process, accepting that and expecting that this is probably going to take some time to achieve this with people, and allowing for that in kind of what you expect to happen. And it is important to offer ongoing support, which has made me realise there's something I forgot to say on the slide before, which was that it is really important to have provision for providing ongoing support for people when they're going through this process. The feedback that we've had from people is that it's really important, and it makes a real difference to being able to carry on with it. Just having that check-in with someone and knowing that you're not doing it on your own can really help carry on and achieve the success. So it's a really important thing to make sure you've got that in place as well. Next slide, please.
So just a few reflections. So we have a range of outcomes with the people that we work with in our clinic. We don't have success with every patient. I don't want everybody to go away and think that we do. Some people do make some bigger changes straight away. More often people kind of think it over, make smaller changes over a longer period of time, or maybe they take some time before they're ready to start reducing. This very much fits with the stages of change model that we've mentioned. So you might not feel like you've done anything, but actually you might have moved the person along in the stages of the change and that's really important. I think that fits with what Liz just mentioned about the sort of ongoing support. So actually you might have sown that seed in your first meeting with somebody, but actually if you can then sort of meet with them on an ongoing basis, actually you might kind of see them along that journey of change a little bit more. So here are just a couple of quotes from some people that we've worked with in our clinic who took part in an evaluation a few years ago. So I thought these quotes were really nice because they kind of summarise what we're saying, but from the patient point of view. So I won't read them out, but you can just read those 2 quotes yourself.
And then on the last 2 slides, Nicola, I think we have some resources. There's probably a lot of stuff on there, but if people can look up further things, and I think you said that the slides are going to be emailed out so everybody could have a chance to look at those later.
They will. Thank you so much, Liz and Vivian. That was really, really interesting. I'm sure everyone found some really useful and insightful information there. Yes, we will share the recording and we'll share the slides so everyone can access the resources that Liz and Vivian have put here. So thank you very much both. If anyone does have any questions for anything that Liz and Vivian have spoken about, please do pop them in the chat and we'll pick those up at the end when everyone's spoken. So thank you. And now we'll move on. Thank you. Now we'll move on to welcome Kerry Page, who is Programme Manager for the Rethinking Pain Service at Keithley Healthy Living, speaking on her experience of the socio-economic and community support elements of chronic pain management. And Kerry is also really pleased to be joined by Richard, who will be sharing his experiences of living with chronic pain. So I will hand over to Kerry.
Hi everybody. So as Nicola said, my name is Kerry Page. I'm Programme Manager for a new programme which is aimed at supporting people in their community who live with long-term pain. I think it's a good point to make at the start is that we concur with everything Liz and Vivian has said there, and very much the basis we're working on in terms of behaviour change in this programme, and some great insight there that we'll go back to. So I'm really pleased it's being recorded. I'd just like to set out so my background. I'm a former public health nutritionist working in communities, and from then I worked as a project manager with a very much a co-design background to the projects I implemented, and some of those were research projects, some in primary care and some in communities. So that's my background and why I kind of came on board with this innovative piece of work originally that started with a pilot around the ICV wondering what would happen if the people we're working with in primary care, if we really collaborated with the voluntary and community sector to give them a different pain journey in terms of really proactively connecting their medications and clinical treatments with holistic whole person support that's out there in the community and happening. And I think COVID really flagged that, that, you know, there's this massive resource out there that actually, you know, came into its fore when COVID happened. And it really opened people's eyes to think, well, actually, there's something we're not drawing down on here that can reduce pressures in primary care, but more importantly, can really help people with long-term pain who might be at the end of their, you know, no longer cure-seeking, medication-reliant, isolated, marginalised in communities. What can we do with those people? So the pilot had a remit to go out and just explore that through co-designing And there was 2 partners. So there was ourselves at Keep to Healthy Living and Hale, who are in another part of Bradford. This programme is Bradford District and Craven wide. And there's 2 approaches. One was what happens if you have a light touch approach, you know, just information provision, digital support, resource. And then our smart, and that was a broader base, 500 patients who were referred. I would say that in terms of Keep to Healthy Living's work, we worked with a small cohort of people who were, say, for example, mild to moderate mental health conditions, very socio-economically deprived areas, say in Keighley, people who were taking a lot of medications, and people with learning disabilities. So the 2 approaches were different. One was light touch and one was really intensive support. And I'm going to tell you right now is that in terms of looking at tackling health inequalities, the more time resource intensive support did wield the greatest impact for people who were referred. And, you know, I would say that, you know, the usual suspects who could access that light touch support did and got a lot out of it, and that's brilliant. But what people were really enthused with this pilot was what happened when we really dug down into this person, listened, used motivational interviewing techniques, spent time and handheld them into community-based resources that met their preferences, their needs and their circumstances, you know, and that they told us they wanted. So that's what happened, and from that there was so much interest in this little pilot that the Bradford District and Craven Partnership decided to try and scale it up and out across Bradford and Craven, which is an incredibly diverse community in terms of its demographics. And this morning, for example, my colleague and I have been up in terms of working with people in chronic pain in rural areas and in farming and such. So we've got quite a task ahead of us, I'll be honest. So the approach is to work with people holistically while being really connected with their GP. So if I could have the next slide, please, Nicola. Quickly, those are some of the partners there, and you can see we've got psychology services. They're involved in tier 3 of our delivery. Very important, you know, number 1 here is the people we're working with. We've got our VCS lead partners. We've got 3 academic research partners, and I've popped the Academic Health and Science Network on there because we've done a little bit of focus group work with them. We've got a clinical governance team behind us who are GPs with special interest in pain. So, for example, slipping pain there that Liz and Vivian pointed out, Asim Sullivan is very much involved with them. And we've got a team, an on-the-ground team. So I'm going to quickly explain the approach, and this is not rocket science to anybody. You've got people who are no longer cure-seeking. You have got people who are on opiate medications or who want to be on opiate medication. You've got people who are isolated, marginalised, and I would say who have been through most of the options available to them, be it rheumatology, physiotherapy, gynecology, and I'm not using, these are words that have been used kind of at the end of the road where the people working with them, they might have had CBT, you know, 8 sessions of that. I kind of don't know where to go with them next, really. And this is a part of what you were talking about earlier, is what we work then with them with health coaches. So the first point of contact, and Richard will talk to you more about this, is a health coach makes contact with that person and introduces what might be a very new concept in a medicalised world of demedicalising pain and introducing the community-based support offer for that individual. And that's been the surprising thing is, you know, when the people we've talked to really didn't see this as an option for them or know how to access it or were unaware of it. So how this works right now is that people are referred by their GP. They are contacted by a health coach. That you talked about listening, Viv and Liz. You know, first call is generally just letting people who are really frustrated get it off their chest. Just get it off their chest. And then we go from there. And the key thing we have found through this piece of work was engagement. We are on a circular and not linear pain pathway with these people. I have to make a case for this, that this piece of work is not about discharging a patient. This is about working with a person. Some people will not take many contacts or need a lot of support, but some will. So each person is, you talked about working with them on an individual basis. A hard argument to make to a funder, really hard, but I was very, very passionate about this. That we've got to give some people more time, and we've got to work more intensively with those people if they need it. So what we found the most important thing was doing the engagement work, introducing the concept of other support, finding out what that person knew, giving them examples of if they had no idea of what type of thing they might want to try, if they really didn't know. But key was getting them to a point of readiness. And that, like I said, that took sometimes a long time and sometimes not much time at all. And then what we do from there is they then can access some pain education, but we don't call it that, sessions, but where we really talk to people about what pain is, how your body responds to it, how you might feel it. But that session then comes away from medications and does come into, it's noted, it's discussed to some extent, but the whole session moves into, well, yeah, but that medication might not be helping you anymore, it might be having harmful side effects to you, etc. What else might you do? How do you take back a bit of ownership of your pain and manage it better day to day to improve your quality of life or restore some quality of life? So from there, we have, so tier one, I'll give you these slides which explains the journey for the patient and person, but is to kind of look at then who needs more intensive support. And that's where we've got trained pain social prescribers who come in to work and handhold that person more. And they might access things like a module on sleep, a module on managing emotions, relationships, guilt, lack of energy, and so on and so forth. A lot of the co-design from the pilots told us what those sessions would be. I think it's important to say as well, peer support has been a massive success of the pilot. Nothing is more powerful, and Richard will talk to you about this. I can't even tell you how many people Richard has sent into exercise classes. Yes, you heard it. Getting people with pain to move more and tell them that that's going to help. Well, nobody does that as well as Richard, so I hope he'll mention that. So then there's that more intense support for some people. The peer support runs in the background, constant proactive signposting by people who are situated in their communities. So we don't pretend to know all of Bradford, and if you go into central Bradford and you've got mainly Urdu speakers, we're working really closely with the voluntary care sector, and we are funding them and you know, not expecting them to do anything for nothing. But I would say a lot of the things they've already got going on, which are already funded, they're happy for these people to access because they want people to use their groups. Where there's gaps, we're going to do some really interesting work with the universities about accessibility, and that's in terms of the education programme and accessibility of the community support offer as well. If we have gaps in provision in certain wards, we're going to pick up on that and do some work to see how we can help people. So just, I won't go through all these, but I just thought it was worth listing for some people who want to look at the slides later. Nicola, if you just move through the barriers we encountered in the pilot to people engaging with more holistic, whole-centered approach to managing pain, which I suppose a lot of those won't be a surprise to anybody on this call who seem to have a lot of knowledge. But actually, it's interesting for some GPs. Was quite a surprise, you know, genuinely surprised, because they didn't have the time to hear that somebody felt guilty about their family and guilty for asking for help with transport and so on and so forth. So that was quite interesting for us. And then just on to the next slide, because that just gives some examples of some of the things that people so far have liked to engage with. There's hundreds of these, but I just thought I'd give you a snapshot of some of the things that we'll signpost people into. And then just moving forward, I'll explain a little bit about the referral pathway. I've done a little bit of that. And then I'm going to pass over to the person who's really interesting, because what Richard's going to do is actually bring this to life for you. So the service is for adults aged 18 plus, some of which I've described this before, but usually with high impact pain, no longer cure seeking. The GP is asked to have a conversation about change for them, adaptation of, maybe adapting some lifestyle change behaviours, just opening their mind to the idea of other support. So that's really important. We're doing a lot of work with the GPs as well about how they introduce that, because I would say as well though that having the close connection with the GP and the GP referrals work for us really well in terms of trust of the person coming to us, trusting they're being sent somewhere where they will be safe with their pain. And that's been really key for the exercise programs and the diets and nutrition programs we're doing as well, that they feel they're in a really safe space. Just moving forward then, I'm just giving you some examples of the surgery posters that are going up. These are letting people know the service is available. And next slide, Nicola. And one of the other things we've been doing is looking at accessibility. Now, this is literature, and this is not ideal for everybody. A great part of the next 18 months is we are going to do some really innovative work in communities through co-design to look at how people want to receive information, how they access information, and in what format they want to engage with what we're doing. So while that is just an Urdu translation of a patient information flyer, we have got such ambitions for this piece of work, and we're all really excited about it as a team. And just say, moving forward, very quickly, referral method for rethinking pain is through GP Assist under their pain management tab. So at the moment, only GPs and the MSK and physio services can refer in. The reason for that is, and I think this comes back to a piece, so we've got a clinical psychology team in tier 3 doing CBT. But what's really interesting about the VCS being involved in this and being the lead in this is what we know with the stats for pain. Say there's different stats, but if we say 1 in 5 people in England have chronic pain, high impact pain, how on earth can primary care reach all of those people? It's not possible. So, I think it's thinking about that ripple effect as well, and reach and collaboration. And I'll keep coming back to that because I'm a great advocate of it. But I think it's something that needs to be reciprocal, and I think it needs to be mutually beneficial. And I think it's been quite interesting in even getting the VCS onto System 1, has been a job and a half, getting that, that trust for us to be on their system so we can access patient data. And we're still now in terms of working together. So imagine on System 1, we're logging something, if say a person now does Tai Chi in an art group or has lost weight, for example, we can log that on System 1. But coming back to the qualitative side of that they've joined a social group, they've made friends, they've told us they've come off anxiety or depression medication. How do we marry our system for collecting that longer journey with yours so we can really see change for people? So I think going forward, working collaboratively, there's something for us to be really thinking about there. And just moving forward, just an example of the understanding pain sessions which are about to begin, which I've already described, Nicola. And I'm not going to talk you through all of this because what I'm going to do now is going to hand over to Richard, because essentially what he's about to tell you in terms of how he worked with us will be these steps through tiers 1 and tier 2 of the service. It's the first time we're trying to work in a really seamless way in Bradford as well. So we're trying to link that first point of contact from the referral through to the social prescribing, through to that intensive support into psychology services. And the last link that we're just making at the moment will be in with the other services, which is community mental health, physio, gynae, rheumatology, and also into secondary care. So in Bradford, we're testing out a model Whereas if we link everything together in a one pathway that's seamless for the person accessing it, what difference will that make for them? And what difference will that make for primary care? That's a massive ambition in terms of our evaluation programme, but hopefully that's why we've got the right research partners on board with us as well. And so I'll be really interested to see what happens over the next year and a half. So the tiers explanation will be sent through to you, which you can have a read of later on if you want to. But without further ado, I'm going to move out of my chair and I'm going to let Richard tell you what his experience has been of working in this way with this service. So I shall shift over and move Richard in. Go.
Hi everybody, this is the first for me. My name is Richard Taylor. A bit about myself. I'm an ex-builder. I first came across pain when I was 23 years old when I pulled my back out, and from then on I've been on constant medication, from tramadol to, well, at one point I was on tramadol, hydroxychloroquine, naproxen. I was going for injections at Yorkshire Clinic every 9 months in the base of my back, and then I went on basically carry on working until I was 56, where I contracted ILD, which took 3 years to find, in situ lung disease, and then went on to steroids, and I was in a bad place. I couldn't go to work. At one point I didn't want to get out of bed. I'd go see my doctor at the hospital, Dr. Sultan, and she eventually got me onto these steroids and said, look, you have to go off your steroids. So I went to hydroxychloroquine. To cut a long story short, she said, you need a pain patch. That's what I'm going to recommend for you. So I went along to my GP, who said, no, I'm not giving you a pain patch. And I'm like, you know, why not? I've been on medication all my life. And he says, no, I'm going to try something else with you. He says, that's to go to do Tai Chi. And my sort of response was, what? You know, why Tai Chi? What's yours? She says, leave it with me and we'll just work around this. Yeah, so whatever. Crawl back into my little hole, like, you know, nobody wants to bother anyway. And I got a phone call off Kerry. I've just been talking to you. And this way I just come down here to KHL and try some exercises, which is a big thing. At the time they were doing an exercise with ballet, believe it or not, and positive strength. I did those 2 sessions, one on the Tuesday, one on Thursday. Went home on the weekend on the Saturday night. I said, yeah, we're back there. No way, I couldn't walk, the pain was horrendous. I still carry. And then along the way there came more lessons. So I'm now doing, today I've done ballet, I do Tai Chi, ballet, positive strength, I'm doing a cardio conditioning one, yoga, and it's all making a big difference. To the point of stop doing these exercises like Christmas, you're back to your full-time pain. So yeah, I can actually tell you now and justify that exercise does work over painkillers. I'm down at 2 cocaine a day now from what I was taking. And the physical side of things, you feel better yourself, affects your mental side. You feel better yourself mentally. To the point of fact, even at the weekend, I saw somebody in the shop at the co-op, local village relations. Hey, look at you, Richard. Oh, I saw you 2 years ago, you didn't like that. You know, they thought I was sort of like end of life to look at me. I've lost 2 stone in weight. And it's just been a big change for me. a big thing has been learning to do things that people take for granted, or we take for granted, or you all take for granted. They're silly things like breathing. I came here and I started doing yoga. Do I breathe? Yeah, I breathe. From here. Not from here. I didn't know what breathe from here. It didn't exist to me. I'm up and down ladders, stuff on my shoulder. It didn't breathe down here. It took me 2 weeks more to learn to breathe and know that I had a diaphragm. And learning this about the diaphragm has been a big, big thing for me, as in controlling pain. The extent of going for an MRI scan, for example. I used to an MRI scan, eyes clenched shut. Yeah, get me out of there sooner the better. The last one I had, MRI scan, eyes open, a breathing exercise I've learned with yoga, no problem. Great. So yeah, it works. And it's taken me to the point of, I'm even saying to other people now, I see them downstairs where we do it, all exercise, give this a go. No. Got people down here in their 80s, and I'll say, don't look at them. Don't think you're working with all this. You're not. Look at yourself and what you're going to gain. Look at me 18 months ago, I couldn't walk in this building. I staggered through this building, and it's made a big, big difference. And I can't push it enough, really, for doctors to maybe, yeah, my doctor said, you're not getting a pain patch. I said, off, I've had painkillers all my life. But it works. Exercise works when you've got the right people telling you and showing you what you need to do. I feel like it's also taken me on to volunteering, and I'm volunteering at KHL, which gives me another aspect of a feel-good factor. And basically, it's just where I am, and I can't advocate enough about pain. And I get a lot of support here from like security. I'm a ballet teacher, I have yoga, I have loads of peer support. It's absolutely brilliant. And it's really what needs to be done, opposed to, in my opinion, opposed to just dishing out tablets. Back then, yeah, drugs were a thing. I went to work in East Germany just after the wall came down, building houses in East Germany. I had to take 4 months worth of tablets. I had to take a big letter with me. And you see the case I took full of medication for pain. Yeah, like that. And you could try going through border control with tramadol, etc., etc. Yeah, I lived off them. Oh, it's smart is. So much so I became immune to them. You don't need them.
What pain medication are you on now?
Pain medication now, I'm just going to do cocaine all day. The exercises. That's it. That's all I need. I take some other stuff for me, for the breathing, but pain-wise, I'm down to 5 milligram steroid. That's where I'm finished. No more steroid, down to that. And it's been absolutely brilliant. For the doctors really to push me to this place where I want to say, no, I don't go there. Yes, I've come here, and yes, it's worked. It's been hard. It's been hard to mentally to stick at it and go, yeah, and another one, and another session, yeah. But eventually it becomes part of your routine, part of your life, and you enjoy it. And I can say no more than that, really. Yeah.
That's brilliant, Richard. Thank you so much. I will just say, when Richard said he came almost called into this building, Richard was the very first phone call that was made on the pilot piece of work. So we're a year and 3 months down the line. But I would say this is, to see Richard sat here talking to you guys today makes me extremely proud, and comes back to another part of what we really want to do here is the peer support aspect of the work across Bradford, and also empowering people like Richard to come on board as experts by experience, because nothing is as powerful as him talking to somebody else. So
when I started here, I was like, hey, this chair like this, I didn't like this.
So I just want to thank Richard so much for coming on today. I'm just really, really proud of him, to be honest. So thank you, Richard.
Thank you, Kerry, and thank you, Richard. I think we'll all agree that was such an inspirational story, and it's really lovely to see both of your kind of relationships with each other as well, and how you've supported it, and how Richard's now supporting others in the service too, which is really, really fantastic. So thank you so much, Richard. I know this is a bit daunting, so I really appreciate you coming and speaking today. Kerry, did you have any of the other slides that you wanted me to pop up, or did we want to move on to Lindsay?
I think you probably need to move on, and as I described, the rest of the slides people can just have a read through, and my contacts are up at the back as well if anybody wants to get in touch. I'm quite open to that as well. There's some people, if anybody wants to ask any questions. Is there any, I don't know if you're doing a Q&A at the end. I think you are.
We will, yeah, we'll pick up any questions
lovely.
from the chat at the end.
Great.
Brilliant. Thank you so much, Kerry and Richard. So our final guest speaker, really pleased to welcome Lindsay Clayton, who is the Medicine Safety Officer at Wakefield District Health and Care Partnership as part of West Yorkshire ICB. And Lindsay will be speaking about how to use prescribing data to identify patients who are potentially at risk of harm. So thank you, Lindsay. I'll hand over to you.
Thank you very much, and it's hard to follow Richard, to be honest, and I think we can all say that we're extremely proud of Richard and what he's achieved, and I think it's always really good to put the patient at the forefront rather than just looking at medication like I do, so that's great. So I'm Lindsay Clayton. I'm the Medicine Safety Officer within the Wakefield District Health and Care Partnership that works within the Medicines Optimisation team. Next slide, please. I've been in post since the patient safety alert came out to appoint a medicine safety officer in large healthcare organisations, and a decision was made to appoint a medicine safety officer to primary care medicines optimisation team. I think the rest is history. I think we've all done that within our own organisations, and just to let you know that I'm a technician by trade as well, which is always sometimes quite useful to be aware of. So in Wakefield, we're a 390,000 patient population, give or take. We've got 34 GP practices, and just for future slides, we've got 33 practices on System 1 and 1 straggler on EMIS Web. So my main role is obviously to support practices in primary care, GP practices to adopt medicine safety cultures, to report medicine safety incidents, and to make sure that where possible, where we can, that prescribing is safe for patients and also for prescribers to practice safely as well. So one of my roles is that I have access to all 33 System 1 GP clinical systems via smart card. I can do this from home, from the office, it doesn't really matter. And my role is that I have a suite of medicine safety searches that are down to either themes from local incidents or things from my MHRA drug safety updates, where I run searches on a regular basis, which may flag patients up that are potentially at risk or of a concern. And there's quite a lot of those, and some of these are related to opioids or controlled drugs. So I link in, so I'm not patient facing, but what I do is I review patient records, and if I think something's niggling or there's a gut feeling or something's not right, I will then task either the GP prescribing lead, or I'll task our PCN pharmacy colleagues out in primary care to take a look and either confirm what my concerns are, and then to do any tasks relating to that. And the reason why it all fits in is that I'm also the controlled drug lead for the team, but I also lead on pain and MSK and dependence forming medicines, as well as respiratory and wound and home oxygen. So my role's quite varied. But as you can see with that chart, that in Wakefield we prescribe a lot of high dose opioids. So high dose opioids are classed as opioids that have got an oral morphine equivalence of equal to or more than 120 milligram per day of morphine. And as you can see from that chart, we are outliers significantly nationally, and we know that we've got a bit of work to do, and we've been progressing work. So the next slide, please. Okay, so the aim for me really and as a team is that we need to try and support practices by identifying patients who are on high dose opioids that's non-cancer related pain with or without the co-prescribing of gabapentinoids, because we know, for those of you, we know that that's also a risk in terms of respiratory depression and potentially death. Patients prescribed multiple opioid controlled drugs, sedative medication, so polypharmacy, and things like anticholinergic burden as well, which is a concern. I also look at anomalous prescribing activity, so things like types of drugs, volumes, ordering activity, and then also non-controlled drug activity, so things that can be abused and diverted or misused, so things like cyclizine injections. I've got a few patients of concern that unfortunately have got issues, shall we say, with cyclizine injections, and oral to a lesser degree. Loperamide, we know that it can be quite abusable in high doses, so that's very rare that we come across that, but also things like hyoscine patches as well. So we'll look at those items that could actually lead us into more concerning information. And then I also monitor red drug prescribing. So these are the things that should only be prescribed by specialists in an acute care setting. So things like ketamine and cannabis-based products that we don't prescribe in primary care in our area. And then I provide support and advice and signpost accordingly as required. So next slide, please. So the initiatives that we've done locally is that a part of a local GP contract, we've asked that all practices produce an opioid and gabapentinoid strategy. This was to enable practices to manage patients prescribed high dose opioids and how they were going to try and look at how they're going to change their prescribing behaviour going forward. So not always going back and trying to tackle patients on high dose opioids or long-term opioids, but actually change their prescribing behaviour in line with national guidance. So we're never trying to go back, that we're looking going forward and reducing our prescribing rates. All GP practices submitted their strategies, and it's been a good way for them to focus attention and action, and actually it's mobilised them to be more proactive with this cohort of patients. So I offer bespoke presentations to practices and PCNs, providing their data, providing their case studies of their patients. And that's a really good way to get their attention and actually realise that they have got some patients on their list that needs attention, that needs help and support and potential signposting. And we promote the use of ARDNs and local clinical searches to prioritise patients for review, and we try and prioritise patients with a higher oral morphine equivalent, because if you tackled everybody, it'd just be futile, because there is unfortunately a lot of patients that are on high dose opioids. So next slide, please. So how do I do it? So we have something called the NHS Business Services Authority, so those who don't work in primary care. When a patient presents with a prescription, whether it's electronic or paper, to their community pharmacy, the community pharmacy dispense that product and they endorse what they've dispensed on that prescription. That then gets sent up electronically to the NHS BSA in Newcastle, and they then process the prescriptions to detail what was on the prescription, how much, quantity, strength, type, and then that is loaded into a big database, probably one of the biggest databases in the country, well, in the European Union, put it that way, or maybe the world, who knows. And then that provides us with access to look at what prescribing activity has taken place in our local area. So I export controlled drug related data, so opioid related data, and it's normally around 2,000 lines per month. And I sort of manipulate that data to make sure that any unusual quantities, unusual drugs are flagged up to me, and that's come with a bit of experience on how to manipulate the data. So by the end of that, I have probably around 30 to 40 items that I need to look into in a bit more detail. So I will go into the patient's records, I'll find that drug, I'll review the patient, and sometimes it'll lead to nothing or a really quick intervention like a quantity change to make sure it's not a maximum of over 30 days per prescription, or if I think it needs further escalation, that's when I'll task the necessary healthcare professional. So I'll also run searches in the clinical systems again to identify items that are a bit rogue or anomalous that we don't routinely see in primary care. And sometimes I'll try and intercept that prescription before it's dispensed by the pharmacy, just to ensure that the patient doesn't get the drug dispensed. So in terms of proactive identification via System 1 clinical searches, we have a variety of searches that will identify patients that may be on oral morphine equivalent of fentanyl patches over 120, oxycodone and things like that. Unfortunately, I don't have searches that has a total oral morphine equivalent if they're on a variety of opioids, because that can be very complex to do, but I'm getting better. So next slide, please. So these are some examples of the interventions that I've made. So I came across a Longtech 80 milligram tablet for 42 tablets, which is an anomaly. So it's normally taken twice a day. So I was really unsure why 42 were prescribed. On review, the patient was prescribed 3 tablets twice a day, which is equivalent to a weekly prescription, which sometimes flags some concerns when you see weekly scripts. And that equates to around 750 milligram oral morphine equivalent. And we know that the maximum recommended dose in non-cancer pain is 120, so excessive. The patient has also got a diagnosis of COPD, prescribed amitriptyline, maximum daily dose of gabapentin, respiratory depression. It came apparent through looking through the patient's records there was a long history of drug-seeking behaviour. At the previous practice, he wanted prescriptions early, repeatedly, because he was going to funerals in Scotland. But in the new practice, he used the same excuse that his mum had died and he needed to go to Scotland. So that it flags certain concerns up, that there's some inaccurate excuses being made. He was early ordering, lots, losing prescriptions a lot of the time, leaving them on a holiday, and fabrication of stories. So I tasked the GP prescribing lead to highlight my concerns. Long story short, the patient admitted to diverted to his son, but then admitted that he actually was overusing them himself, because when they started a reduction, the dose was far too low to what he was really taking. So the patient is still undergoing an enforced reduction regime after 2 years. The patient has been trying to attempt to delay the reductions by utilising different services like pain clinic to halt the reductions, but the GP has been fantastic and actually has built up a really good relationship with the patient, and they're still undergoing a regime, a reduction regime. So a positive outcome, however you want to look at that. Obviously the patient wasn't too enamoured at the start. Next slide, please. So some little ones. So dietary coding, 120 milligram tablets, 168 per prescription. So I flagged that up as a concern. It was taken twice a day, but the patient had 1,000 extra tablets in the 10-month period when I look back at the ordering history. So I highlighted my concerns. The patient admitted to taking more than directed. Quantity was reduced and they went a gradual reduction plan to the original dose. I spotted a script for 240 Zomorph. Again, that's excessive because you'd expect 60 maximum on one prescription. It came to light that the patient was travelling to Philippines for 4 months at a time. So that was just around educating the practice to say that actually the maximum amount is 3 months, but you still may not only want to limit it to a month, and that they need to access healthcare where they're visiting. Next slide, please. And then a patient was on 30 fentanyl patches a month. So again, I went in and took a look at that. The patient was ordering these every month. They said they weren't sticking, so they had to replace it every day. I suggested that they try tape, and apparently the pharmacist spoke to the patient. They had tried tape and it worked fantastically. So the question was, well, why were they still ordering monthly? So we just made sure that any residual stock was used. And no further prescriptions were issued until that stock had been used up. So next slide, please. These are item anomalies, so things that lead you on to something. So a patient had ondansetron injection on repeat, so that's used for as an antiemetic for sickness and nausea. Complex history, and had a history of substance use on the records. On review, they'd had an extra over 1,000 ml of oxynorm liquid, an extra 94 zolpidem tablets, and 2,500 extra cyclizine injections. And they are at risk of abuse and diversion due to the hallucinogenic side effects. So it was clear looking at the journal that the patient was exhibiting drug-seeking behaviours. They were accessing out of hours, spilling, breaking ampules, requesting prescriptions to be issued by the practice when they're actually an inpatient in the hospital, which is a red flag, leaving medicines behind on holiday. So I flagged up my concerns again, and now they're being managed as an MDT approach with a GI consultant specialist pain clinic, and the cyclizine prescriptions are being reviewed and monitored regularly. Next slide, please. Okay, so while I was checking a nebulizer use in an asthmatic to make sure that bit was safe, I came across that the patient was prescribed 3 strengths of fentanyl patches, morphine oral solution, high strength, diazepam, diazepam, and pregabalin. This was for non-cancer related pain. The oral morphine equivalent was 315 milligram, excluding the oromorph. Anticholinergic burden score of 12, severe risk of respiratory depression, and they'd had previous interventions regarding pethidine misuse. So that's an example of how looking at something else can lead you on to another concern, and that patient is currently being reviewed. Try and optimise the patient's medication and pain control. So next slide, please. Morphine suppositories, again, not routinely seen in primary care. And the patient was also prescribed amitriptyline, promethazine, pregabalin, fentanyl patches on oromorph. So the morphine suppositories were originally started because the patient was not able to tolerate the oral oromorph because of her condition. But unfortunately, when the oromorph was being able to take orally again, they also kept using the morphine suppositories. So the opioid dose just escalated into something that wasn't intentional. This was highlighted to the GP prescribing lead, and the patient was also asking for morphine injections after an hospital stay, when they do get supply on hospital as well. They were saying that the sun were knocking over the oromorph over the time. They were asking replacement prescriptions for out of hours, when the pharmacy actually said that they've been dispensing the suppositories with no problem. So at the moment, the patient is undergoing a fentanyl patch reduction, and they've been having positive consultations. They've agreed that morphine suppositories should only be used in exceptional circumstances, but since then I've followed up the patient and they've since been stopped, and the patient fentanyl patches are still decreasing, and the patient is positively engaged and feeling the benefit. And this is everything around what my job is to not judge any patient, but actually try and signpost patients to GPs who might be unaware of all this that's happening behind the scenes, because I've got the luxury of being able to really interrogate the patient's records and advise accordingly, which not a lot of clinicians have the time to do. So next slide, please. General top tips. For GP practices, CD quantities not to exceed 1 month's supply, directions to be clear, no PRN or vague directions, to be aware of common drug seeking behaviours, and use a search facility to put lost, missing, stolen early, because then you'll see the raft of how many times a patient is asking for the same thing, or how many times they've lost prescriptions, which again should be a red flag. Really monitor the out of hour 111 A&E walk-in centre notifications to look. Oh, sorry. Can you just go back? That's it. To see if there's any themes and to make out of hours aware. To promote the use of only to be issued by authorising prescriber, which is a direction from our controlled drug accountable officer, to put that on the labelling directions of items that you do not want to be issued by any other provider than the GP practice, and that will be seen via the summary care record. Liaise with their pharmacist if they've got any patients of concern, and vice versa. Have a record who can collect prescriptions on the patient's behalf, especially if paper FP10s, and same to happen at the community pharmacy. And to promote the controlled drug incident reporting tool and clarify what triggers a controlled drug submission, because to be honest, the amount I come across, you couldn't submit an incident report to CDAO team every time, but there's a trigger of where actually it becomes more serious rather than just a quantity anomaly. Next slide, please. And then the barriers. My capacity as MSO, it'd be a full-time job intervening on controlled drug, opioid and other medicine safety things, but I haven't got the capacity because I do other things. But the volume of interventions is quite significant. Getting GP practice engagement, I'm fortunate. I have a fantastic relationship with all our GP practices. I've worked primary care in Wakefield since 2004, so that's been built up over time, and it's trust that I'm not just I'm there to support them and to advise them, not to sort of chastise them if they're doing something that I wouldn't routinely see. There's a reluctance to tackle patients who are known to be difficult, and that's really hard because it is quite tiring. I used to run benzodiazepine reduction clinics in primary care, and even that is quite tiring at the end because you've got to get over and you've got to listen to patients for them to let you know what their concerns are around reducing or stopping these type of medication. Lack of capacity for GP practice in this current climate, like everybody has. We've got conflicting priorities, lack of skills and limited options around opioid reduction clinics. I mean, it's great to hear Liz today, a colleague, around what they provide in Leeds, but that's not what happens everywhere. So we need to think about how we can improve services across our footprint. And there's a lack of faith in other services. So locally, we've had historic lack of faith in things like pain clinics, where they just seem to go in and come out on multiple pain medications. And I think we need to get better at that, and I'm sure we will do when we start to review pain and MSK services locally. So I think my next slide is any questions. So really quick, I'm more than happy for anybody to contact me out of this meeting for any further information around searches or well, any advice really around my role in this area. So thank you for listening.
Thank you, Lindsay. That was really, really interesting, and I'm sure you will get people taking you up on your offer of further support. As always happens, I think the time has absolutely flown by. We do have maybe about 5 minutes for a Q&A session from the chat. So I have been collating some queries, so I will try and get through a couple of them. If we don't get to your question, apologies. We will try and answer these and come back out with a bit of a FAQ Q&A document that we'll share around with everyone. So there was a question, it was when Liz and Vivian were presenting, and it was around, can you recommend any resources for patients that are pre-contemplative, I'll try and say that word right, to help support in between appointments? So is there anything patients can kind of be reading, watching, doing in between that you're aware of?
One website that we found really useful is Flipping Pain. I don't know if it's something that any people have come across. It's really useful, very accessible. It's got things in different formats, and people can go away and kind of access it as and when they're ready. So that's something that I often refer people to, and it's also something you can encourage them to share with their friends and family as well. So that's definitely one thing. Don't know if there's anything else Vivian you'd say.
I was going to say the same thing. It's a great website, so definitely pointing people to that.
Brilliant, thank you. So there was a question in the chat while Kerry and Richard were speaking, which was someone actually querying the kind of geographical spread of the paid service, which I think Kerry's mentioned and I did answer in the chat, but I guess there's a question more generally about how do people find out about kind of services that might be in their areas, such as Rethinking Pain. From my perspective, I'd say reach out to your local patient safety collaborative and AHSN, because we might be able to put you in touch. But Kerry, do you have any thoughts?
One thing I would suggest is the POPPY study, which I think is the Bradford and Leeds Research Institutes are currently doing some work to map different pain services across England, at least. It might be the UK. So they are quite aware of who's doing what across the patch. So a contact to the POPPY study might be helpful to find out what else is going on. They're starting their research in April. I think it's a duration of 12 months, so they'll be reporting on that as well at some point in the future.
Brilliant, thank you, Kerry. There were a couple, I will say, of quite pharmacy specific questions, which I am not clinical in my background, but I will try to read these out for if any of our speakers are able to give any thoughts to these. So there was a question around the significance of natural and synthetic opioids, opiates, and how do we understand what we're talking about in pain management? Anyone?
I'm not quite sure what I would say to that one. I guess the term that we tend to use as an opioid, and my understanding of that is that covers both the natural and the synthetic preparations, and that's definitely within kind of our clinical practice. That's the term that we would use, and I think most publications and things that I've seen recently, that's the kind of the accepted term rather than opiate. I don't know if that helps answer the question.
If it doesn't, whoever put it in the chat, if you would like to add any more thoughts to the chat or come to any of us afterwards, and we'd be happy to pick up further. I do apologise, I've probably misinterpreted that question because, as I say, some of the more specific pharmaceutical side of this is a bit above my head, but thank you for your questions. Time is getting on, so I will try and bring the session to a close now. Apologies if we didn't get to your questions in the chat. As I say, we will collate them and try to send answers out to everything that was asked in the chat. I was going to do a bit of a word cloud around what people would like as future webinar topics. I don't think we've quite got the time now. I did want to make sure that speakers had all the time they needed to speak. So I will skip that, but I will be sending out a survey for feedback on this webinar, and I'll include the question there. Or if anyone does have any immediate thoughts, please do pop them in the chat and we'll pick them up from there. One thing I did just want to mention is that part of the MedSIP programme, we will be releasing a resource library which links into one of the questions that Liz and Vivian answered, which is a nice kind of easy to follow one-page website with lots and lots of links to various different existing resources that are out there. And we can send the link out and it takes you directly to that page. You don't need to sign in like Futures or anything. It's all publicly available information that's already out there online. It's just that we've tried to pull it into one place for ease of finding some of this information on various topics in the reducing harm from opioids for chronic pain space. So we will link that on our websites, which again will send these slides out. So I've put the AHSN website for the Patient Safety Collaborative and the Improvement Academy, who, as I mentioned, deliver the Patient Safety Collaborative in partnership with the AHSN. And the resource library will be linked to via there. I've also popped my email there if you do have any feedback, any queries, or if you're interested in any kind of further information and opportunities for working with us and collaborating as part of the MedSIP programme, please do reach out to me. It'd be really great to hear from you. And finally, I'd just like to say thank you so much for joining, and thank you so much for all our brilliant guest speakers. You'll see all the lovely chat comments in the chat for you. We really appreciate your time sharing your knowledge and experience. And I will draw it to a close, bang on time. Thank you so much, everyone.
Thank you.